So we move the last talk of this session from our friends Dr. Rajinikan Rajakopan from Brunei. He will talk about the DCB angioplasty. What's next? Yes, Dr. Raj.
Thank you, Hui. Hopefully convinced you to move all PCI to DCBs. Bifurcation otherwise, right? Thank you for the invitation. It's wonderful to be here again. Um, so I'll be talking about, so no disclosures. What's happened in the last year or so, in last 1 to 2 years in de novo PCI. So I'll start with large vessels. I was going to talk about bifurcations, MI, but it's been beautifully covered with the last two speakers, so I won't linger on that too much. A little bit about imaging, and then I'll talk some philosophy about DCB PCI. So we'll jump straight into DCB in large vessels. The big news this year was the solution de novo trial, which was published recently. So this was a randomized controlled trial looking at patients with large vessels, and they were randomized, this is important, before the procedure. Okay, so before vessel preparation, they were randomized to receive either a solution sirolimus eluting stent, DCB, or a DES. And they were looking at the primary endpoints. It's looking for non-inferiority, not superiority. They wanted to establish if DCBs can be as good as DES in these vessels. And they had some core primary, secondary endpoints as well. Inclusion criteria, like I said, more than 2 millimeters and less than 5 millimeters, because that's a DCB that we have. We don't have bigger DCBs. That's the most important thing to look at. And exclusion criteria, they excluded SCEMI or unstable end SCEMIs, excluded left mains and grafts and CTOs as well. And they had mandated a few things like one-to-one pre-dilatation, which is important because there were other trials where it was completely at the operator's discretion. And DCB inflation 30 seconds is quite common. And everything else was at the operator's discretion. These are the results. The DES, the primary endpoint, was made in 4.4%, and DES 4.4%, DCB 5.3%, and it was found to be non-inferior. So which was a good result. So we're all happy with it. So this certainly gives some evidence, support to the idea of using DCBs in large vessels, having already established this in small vessel disease. So the conclusion from this study was that at 1 year, solution DCB was as good as non-inferior to DES with a primary endpoint of target vessel failure. But this, and the 5-year results will be done, in due course. This started discussions about a previous trial that came up last year, the REC cage free. And people are bringing this up. This was a negative trial. Again, this was a PCI study, paclitaxel DCB in that case, with or without rescue stenting compared with stents. And these were de novo, non-complex, short lesions, and they used a DCB called SWIDE, which was spray-coated with ultrasound of crystals consisting of paclitaxel and iopromide, which was an excipient. And the usual criteria were followed. And this one was negative. It did not meet the criteria for non-inferiority. And it's actually inferior for multiple CV outcomes at 2 years, with the exception being small vessels. Even within the study, when they looked at small vessels, there it was non-inferior. So that's good. We don't have to worry about small vessels. But this was only a sub-study. It's only a hypothesis. We can't really say too much about it. And earlier we had the 3-year results, again non-inferior, although the difference seems to be narrowing at 3 years. So DCBs are getting more and more equal to DES, closer to 3 years. So something is going on there. But the question is to understand why there is a discrepancy between the two studies. Some of the reasons offered are these. In this study, in REC cage free, they were mainly non-complex, focal, short lesions. And these lesions do pretty well with DES anyway, right? So DCB is better for long lesions, diffuse disease, and so on. And the spray coating technique, which was used in the the paclitaxel balloon, it was considered that it may affect long-term drug retention, might possibly contribute to the events. So we know that with DCB, you don't have class effect. Each DCB is different in many ways. Also, there's a very high bailout stent rate because here the patients were randomized after vessel preparation, which means they have done the vessel prep and decided this is good for DCB. And in spite of that, they had a 10% bailout, which is quite high. And that talks something about the vessel preparation itself. So we need more evidence. The Transform 2 study we should have the data next year. Well, the recruitment's finished. We should start having some data soon. And it's a little bit different here because in the oh, sorry. Let me here. Here, what happens is when we recruited for the study, we do the vessel preparation first, and then we randomize the patients. So it's a slightly different from solution de novo. It'll be interesting to see what that shows. So overall, with large vessels, there is emerging evidence with RCT's registry meta-analysis. There is no class effect. It can be applied with appropriate patient selection. Procedural aspects are important, including lesion preparation and imaging optimization, and the device aspects. The device that we're using is going to make a difference. Moving on. Bifurcations, I don't think there is much to say. I mean, the previous speaker systematically covered all the important issues here, the reasons for doing it, the different ways of doing it. I will just talk about one particular aspect which the speaker alluded to. So there are two ways of doing this hybrid or blended techniques in DCBs. Either when you use a stent in the main vessel and a DCB in the side branch. One option is to put in the stent in the main vessel first and then do the DCB in the side branch. The other option, and there are studies like I think the DEB side and BioLex showed that. The other option is to put in the side branch DCB before you put in the DES in the main vessel. That's seen in these two studies, and there are other studies showing. They're all small studies, about 100 patients, no more. And in my view, I think it's better to do the DCB before the stent. And that's what the speaker said as well. There are a couple of reasons why this could be a better option. It's probably the better strategy. Because once you put in a stent in the main vessel and you have to push the DCB through the stent, there is some concern that it might affect the DCB. You might lose a bit of drug or the coating in it. The second is once you put a DCB through the main vessel stent, you need to do a kissing balloon inflation and finally, and that will distort the main vessel stent. So as long as you have done a good lesion preparation in the side branch, it might be best to finish the side branch with a DCB and then do your main vessel stent, pot, and finish it there. And I think there's equal evidence for all techniques now. In fact, the current evidence, things like DCB-BIF and OCVC-BIF, they're all talking about putting in the stent first and the DCB, but this is likely to change in the near future. So we talked about that. I think MI, again, Sandeep's covered all the important issues very nicely. I'm not going to sort of spend any time on it. There's studies. The most recent study is this year. There's a small study. It's retrospective, about 120 patients looking at culprit lesion primary PCI using DCB, which showed that it is favorable. But again, I think it's been covered, so I will move on to imaging. Just a couple of minutes on imaging. So imaging is important in DCB PCI before vessel preparation for sizing, morphology, calcium assessment, balloon choice, and sizing, and after vessel preparation to see if it's adequately done, to assess dissections, look for intramural hematoma. The ultimate study showed that IVUS will be better than angiographic guided PCI when using DCBs. And there is another study that showed that with OCT, you can look at things like dissections. And if you don't have adequate dissection, you may not get a good long-term result with DCB PCI because dissection would help with better drug transfer and vascular remodeling. So IVUS or OCT could be used before vessel preparation. And after vessel preparation to decide if a DCB is appropriate, OCT might be better. But we haven't quite defined what the criteria and thresholds are for rescue stenting once you prepare the vessel. We need more information on that. So there's a lot more to talk about DCBs. The small vessel diffuse disease, quite well set now, but we need technical improvements. Scoring and cutting balloons are on the up. We use it routinely. The debate between sirolimus and paclitaxel, duration of DAPT, CTOs, which are increasing indication, and also comparison, not just against DES, but also newer devices like freesolve, magnesium scaffold with bioadapter. A lot to talk about, but we don't have time for that, so we'll just do a little bit of philosophy for the last 2 minutes. Deep thoughts about DCB. So while I was preparing this talk, I found there is something strange going on with all the publications and the evidence that we are seeing about DCBs. Normally, if you look at anything in interventional cardiology, this is how everything flows. You have some preclinical or mechanistic studies, early safety trials, then RCT, then you have registries and real-world validation followed by widespread clinical adoption. DCBs, it's reversed. We've been using DCBs for a while now. Then we had registries and observational data. And finally, now we're having RCTs. There is an inverted evidence pattern that I noticed. And it's practice influencing evidence, not vice versa, which is how it's meant to be. So these are all the RCTs that we have on de novo DCB PCI. And you can see the big RCTs are only coming sort of in recent years. But this is completely, if you ask Dr. Liu here, he has been doing sort of 50, 70% DCB a long way before any of these RCTs were published. And that's true for many people in this room. There are many reasons for this. Conceptually, DCB is not a new device, really. It's an innovation or a new paradigm. The rationale is familiar to most of us. We know about delivering antistenotic drugs. We know about POBA. We know about stents. So it's just a device where the metal's gone. So the risk is quite low, and we had a very low threshold to adopt the practice of DCB. Clinical drivers, when it came out initially, DCBs were used for ISR, and we didn't have a good option. Putting a stent inside another stent was never as an exciting option. So we're quite happy to try the DCBs, and the early evidence, registry data was quite promising. So we adopted DCB before waiting for any RCT confirmation. And this use in ISR, I think, created a momentum to launch DCBs into de novo PCI as well. And it's difficult to do RCTs DCB because it's very technique dependent as compared to being device dependent. With stents, a device is the therapy. With DCBs, the operator is part of the therapy. Every step matters. So it's difficult to standardize RCTs. It can be more heterogeneous. So this encouraged real world and registry data first. And that is a difference in how the whole thing came about, as you can see here. And also cultural factors. You know, we had early high volume adopters, initially places like Germany and then in Malaysia. And there was clinically driven adoption, which was not necessarily industry driven. And also because it's a balloon, a DCB, CE approval was quite easy for these devices that are coming about, also supported their use. So all this led to this sort of a bottom-up evolution of evidence and a practice-first model. And that has implications to what we do. You know, it depends on whether you're DCB cynic. I'll be talking about indication creep, selection bias, heterogeneity, wait for RCTs. For DCB enthusiast, I would say that we have to understand limitations of RCT. Let's look at real world insights. Let's worry about the 2% stent failure. Let's do DCBs more. But we are DCB realists, aren't we? So we have to take a middle path here, and this is what we can do as operators. We have to be careful with patient selection, be transparent with our patients about what we are doing here. We have to optimize our procedure, and it's good to have institutional protocols to safeguard us and the patients. And as academics and guidelines, we have to recognize the evidence paradox here, develop prospective registries and some pragmatic RCTs, which reflect real-world practice. And we have to avoid any extremes. We should not practice DCB evangelism. I want a DCB everywhere, but no need to be excessively conservative either. Take a middle path. So in conclusion, we can see that in the last year or so, there has been expanding indications for DCB. ISR, small vessel disease, well said. Bifurcations, MI, large vessels growing. CTO, very interesting. And apart from in clinical indicators like high bleeding risk, you can justify DCB in most cases. The evidence is still mixed. The practice is not necessarily based on evidence at present. So we need to practice thoughtful adoption, perform meticulous procedures, and persist with rigorous evidence generation. I'm pleased to say that we are coming up with the first Asia Pacific stentless PCI course for DCBs next year in April. It'll be in Chennai, so a little pitch for that. I will personally invite most of you here, and I look forward to seeing you all there. Thank you very much.
Thank you, Raj. Excellent talk. Yes, stainless PCI course. Yes, I remember it. Yeah.